Today, we're very excited to launch our Fireside chat presented by Dr. Kathleen Hall. My name is Chusa Moon, and I am an associate professor at College of Nursing at University of Iowa as a member of Education Committee at the National Center for Gerontological Nursing Excellence. I'm very honored to have our third NHCGNE Fireside Chat. This is a free monthly series brought to you by the Education Committee. These series will be featuring the distinguished educators in gerontologic nursing and other experts, sharing insights on key topics in gerontologic nursing. Each chat will begin with a brief presentation, followed by an informal discussion where you can engage directly with the speakers. Today, we have Dr. Kathleen Hall, who will be talking about physical activity in older adults. Dr. Hall is an associate professor of nursing at Colorado Mesa University. She teaches primarily in the graduate nursing program and oversees the adult gerontology nurse practitioner program. She is an expert in gerontological nursing. She integrates education, research, and clinical practice, focusing on professional identity in nursing and health promotion in older adults. She has authored numerous publications and is active leader in gerontological nursing, earning the National Hartford Center of Gerontological Nursing Excellence Distinguished Educator Award in 2019. In the next 15 minutes, Dr. Hall will be talking about the motivating physical activity in older adults. Are you ready, Dr. Hall?
I am. Thank you. I appreciate everybody joining me today. This is my favorite conversation to have and my favorite topic to talk about. So my challenge is to only speak for 15 minutes because I really want to speak for the rest of today. But I'm hoping to share with you some real practice-oriented suggestions so that every encounter that you have with older adults in any setting, you could think about how you might integrate some of this information into your clinical practice. So I have 4 objectives, and the first is to highlight the importance of physical activity for older adults, describe the elements of an exercise prescription, recommend physical activity options for individuals that have chronic conditions, and then to summarize some motivational strategies that help increase physical activity among older adults. So we have to start with defining what physical activity is. And I think a lot of us, especially if we work in long-term care and the care of people with chronic illness, we don't spend a lot of time thinking about physical activity because we think of the gym and the 18-year-olds pumping iron. But really, physical activity is any bodily movement produced by the contraction of skeletal muscle that increases energy expenditure above a basal level, whereas exercise is a subcategory of physical activity that is planned, structured, repetitive, and purposive to improve health. So think about physical activity very generally as either a purposive category or a fitness category. I think that we probably, as just people in the world, think more in terms of fitness categories like aerobics, muscle strengthening, endurance, flexibility, and balance. But most older adults, in my experience, consider physical activity according to their purpose, and that is lifestyle, occupational, transportation, or leisure time. And it's interesting that when you look at any of the CDC or the National Center for Health Statistics in the United States, most of the physical activity that they track is leisure time physical activity. And most older adults that I've worked with over my career will tell you that lifestyle, occupational, and transportation movement counts too. So the benefits of physical activity, in 2018, the federal government in the United States did publish physical activity guidelines for all Americans. And in that document, they tried to summarize the research to date. 2018 is the last publication of this recommendation. And what we know from physical activity is that it does reduce the risk of all-cause mortality. It reduces the risk of falls and injuries from falls. It improves functional status. It improves cardiovascular, respiratory, metabolic, musculoskeletal, and gastrointestinal health. So if you have somebody with chronic constipation and they are not moving, then that is a very easy way to help treat their constipation in a way that's going to have other benefits as well. And there is evidence of improved mental and cognitive health in terms of anxiety, depression, and even dementia. So I tell my students that if you're not motivating people to be physically active, appropriately physically active for their health conditions, you are overlooking one of the most effective interventions that we have in our arsenal for individuals of any age, and including older adults. So before you refer somebody or try to work with somebody to increase their physical activity, you have to consider their readiness for physical activity. And there are two primary safety screening tools. The oldest screening tool is the Physical Activity Readiness Questionnaire, which is abbreviated the PAR-Q. And the original version of the PAR-Q has a series of questions that says, if you have this or if you have that, then don't pursue physical activity without contacting your medical provider. And what they realized was that the original PAR-Q had too many false positives, meaning that there were a lot of people who could do appropriate physical activity that were being told not to do any physical activity. And really what we need is warning labels on couches and lazy boy chairs to say sitting here too long is hazardous to your health, and safe and appropriate physical activity is still indicated even among the oldest old. So they revised the Physical Activity Questionnaire and created the PAR-Q Plus, and the PAR-Q Plus guides people towards safe physical activity based on their medical conditions. Exercises Medicine is one of the resources that I'm going to share with you the most today. And the Exercises Medicine was started in 2008. It is a joint project from the American College of Sports Medicine and the American Medical Association, where they posit that exercise should be considered a fifth vital sign. And so at every opportunity, just like with every vital sign opportunity, we should be asking about movement status and then working with people to increase their movement. And so you're going to see a lot of Exercises Medicine today. But they also have a screening tool, and I have an example of that on the next slide. This is the screening guidelines based on the American College of Sports Medicine to evaluate signs and symptoms of cardiovascular disease, metabolic disease, or renal disease before recommending physical activity. And then if they do currently participate in physical activity and have no disease, which is not really our population, then they should be recommended to pursue light, moderate, or vigorous intensity physical activity and progress from there. If they have known disease, but it's asymptomatic and well controlled, then medical clearance is still not recommended if they're pursuing low to moderate intensity physical activity, and only if they're pursuing vigorous physical activity should they seek medical clearance. Most of us, I'm assuming, are working in the other two columns where they're not physically active on a regular basis, and they do have known disease. And so if their known disease is asymptomatic and controlled, then you can recommend a medical clearance and then follow that medical clearance, starting with light to moderate intensity physical activity and then progress as tolerated. And we're going to talk about what intensity means, because I think you'll see that really there's very few people who shouldn't be moving. So that leads me into what is an exercise prescription. One thing that we need to remember is that just telling people to increase their physical activity does not increase their physical activity. One way to help people recognize the importance of physical activity is to prescribe it and to write a prescription out specifying exactly what they need to do, because then they see it as a medical.
You need to make sure you have a credit card.
Uh-oh, I'm hearing somebody talk about a credit card. Okay. So you need to specify exactly what you want them to be doing, how often you want them to be doing it, and at what intensity you want them to do it. So an exercise prescription is abbreviated FIT. That stands for frequency, intensity, time, and type. Frequency is the number of times physical activity is performed. It's usually the number of times you do something per week. Intensity is, to me, the most interesting component of an exercise prescription. And you can see it's also the one that guides whether or not medical clearance is required. Intensity is the magnitude of effort required to perform the physical activity. And you will see most exercise physiologists using either something called a MET or a metabolic equivalent. If you've ever worked out in a gym, most of the stationary bikes and the treadmills automatically calculate the METs that you expended during the physical activity. And a metabolic equivalent is the ratio of energy expenditure that you expended during the activity divided by the rate of energy expenditure at rest. The Borg scale is, you can Google the Borg scale and find a million of these on the internet, and it has a rate of perceived exertion, and it's a numeric scale. And it's basically, if you're in, like a 1 to 3, you're in low intensity. If you're in a 4 to 6, you're in a moderate intensity. And if you're in a 7 to 10, you're in a high intensity. And all of those are well and good. And you can also see target heart rate calculated for exercise intensity, which is not effective if you've got a patient on beta blockers, because the beta blocker is, or a DIG, because those medicines are blocking their heart rate response to physical activity. So I even left the target heart rate calculation out of the presentation. The intensity measure that I like the most and is most purposeful for older adults, especially those that are currently sedentary, and that is the talk test. And the talk test means that if I can sing during the activity, I have enough air left that I could sing, it is low intensity. If I can talk but not sing, it's moderate intensity. And if I can't even talk, it's high intensity. So if I'm an older adult and folding the laundry means that I can't even talk during that activity, then folding the laundry for me is high intensity physical activity, right? So whatever they can do and they can hold a conversation while doing it, that's moderate intensity. If they have enough air left that they can sing during it, then that's low intensity. And that is a conceptualization of intensity that 100% of us can grasp, no matter what our health literacy is or our prior experience with physical activity. And one of the things that frustrates me with exercise prescriptions is they say, well, low intensity means that you do, walking. But walking, if for some people, is high intensity physical activity. And then you also have 90-year-olds that run the New York Marathon every year, and they would balk at taking a walk being low intensity physical activity because their activity levels are so high. So to me, the talk test is the way to go when you're working with older adults or adults with chronic disease. Time is the duration of physical activity. Of the time is the time of the exercise session, and the type is either aerobic, strengthening, endurance, flexibility, and balance. So the recommendations, again, we're back to the U.S. Department of Health and Human Services guidelines for all Americans. And they recommend for adults age 65 and over, if their abilities and conditions allow, aerobic physical activity that includes a minimum of 150 minutes at moderate intensity. So remember, they can talk but not sing. Or 75 minutes at vigorous intensity, so they can't even talk, or some combination of those, plus at least two non-consecutive days of strength training, and then activities to improve balance and flexibility. An example of this, a perfect example, would be Tai Chi, which is well evidenced to support balance and fall prevention. However, most older adults, especially those that are sedentary, would never even approach a vigorous intensity physical activity. That would not be safe for them to do in an unsupervised setting. You should cross that off your list, okay? what we're really talking about is the same theory and the same principles that we use with prescribing medication, you would be using for prescribing physical activity too, which is start low and go slow, with the adage that some activity is better than no activity. Again, we need warning labels on couches that say sitting here too long is bad for your health. So that even if you're doing appropriate physical activity, then that is preferred to no activity at all. And one of the things that I always teach patients that have been inactive for quite some time, even if they're wheelchair bound, I say just do ankle ABCs, draw the ABCs out with each of your big toes. And they can do that while sitting in a wheelchair. They can do that while laying in the bed. They can do that while watching TV. And basically they take their big toes and they draw A, B, C, all the way to Z. And what that does is it maintains or improves ankle range of motion so that they can dorsiflex their feet. It improves their balance. It'll improve their ability to transfer from a chair to a bed or a chair to standing, and it will lower their risk of falls. So something as simple as that still counts as physical activity, right? With the adage that some is better than none. So when it comes to condition-specific physical activity resources, we're in luck. The most major organizations have developed, and some very well developed, guidelines and recommendations on these organization websites. So you can go to the Alzheimer's Association, American Cancer Society, American Heart Association, American Diabetes Association, and the Arthritis Foundation, and you can look up all exercise recommendations for people that have those specific conditions. For example, at the American Cancer Society, people that have had breast cancer surgery are recommended they have fly fishing groups, Cast for Recovery, because the motion of fly fishing helps preserve and improve the range of motion of the affected side. The Arthritis Foundation has well-developed aqua and land-based physical activities for the preservation of joint function, joint range of motion, and strength. So I can't recommend these websites enough. Some of them also have certifications. You can actually get a specific a cancer exercise specialist certification. You can get an Arthritis Foundation exercise certification. So if you happen to see a lot of people in your practice or your clinic that has a lot of these conditions, then it would behoove you to consider some of those certifications. Exercises Medicine, again, is the joint project between the American College of Sports Medicine and the AMA, and they have free to use open resources, all translated into multiple languages, prescription pads, office flyers, provider physical activity guides, information about how to bill for exercise counseling services if you're working in a primary care or outpatient setting. It is all well developed. It is all free to use. And they have translated patient education resources, including for frailty. So there's really no population for whom these resources aren't appropriate. So this is an example of one of the Exercises Medicine documents. And again, it goes according to the 2018 Physical Activity Guidelines for Americans. And this gives you an opportunity to write out what you would like a patient to do. So for example, you can say, and you can cross out the casual walk, the brisk walk, and the jogging for the intensity of the aerobic activity and use the talk test instead. But you can write out exactly what you want somebody to do, and your prescribing of it makes it more likely that it will happen. So these are, again, they're free to use. You can go to the website and download and print as many as you want. So the easy part in some ways is finding out what to do and helping people do it is actually the more complicated task that we're faced with. And so obviously you have to think about motivational strategies. How do you get them to do what they want to do? Because we do know that just knowing what to do is not enough to change our behavior. We all know we shouldn't, eat French fries and hamburgers every day, but a lot of people do it anyway because they like it. So just because it's bad for us doesn't mean we don't do it, right? So your motivational strategies should be theory-based. They should be congruent with the patient's health goals. So if they're happy as a clam, not doing what you're asking them to do, then they're the boss and we need to respect their decision-making. It also needs to be congruent with their beliefs and values. So in some cultures, something like swimming would not be in public, would not be something that people are comfortable doing. So then you would modify, obviously, the recommendations you're making to that person so it is congruent with their beliefs and values. And a handful of the behavior change models that you will see in the literature and are widely used in clinical practice are the trans-theoretical model of behavior change. And I will tell you that the provider guide through Exercises Medicine is organized according to the trans-theoretical model of behavior change, which basically tailors interventions to a patient's stage of change. The health belief model refers to recognizing the perceived susceptibility and the perceived seriousness of not doing something, and then managing the barriers to pursuing a behavior so that I can achieve the benefits. And so sometimes our job becomes how you navigate or overcome barriers to some behavior, some physical activity behaviors. Social cognitive theory by Bandura, specifically with respect to self-efficacy, is important. That is where if basically self-efficacy, if you remember, is your belief in your ability to do something to achieve the outcome you're expecting from it. And ways to increase self-efficacy includes imagined experiences, so creating a mental model of successful performance. It is vicarious experiences, so watching a similar other achieve and do the behavior you're trying to do. Mastery experiences, so that's successful performance of related behaviors. So just think about ankle ABCs and the extent to which patients can rack up a mastery experience, building their self-efficacy, doing something that simple, even if they're bedbound. Verbal persuasion, which is kind of the coaching and cheerleading function, and then management of physical and emotional state. So obviously controlling the pain and alleviating fears of doing the activity and that sort of thing. One that people are less familiar with that I use often is something called possible selves. And that is conceptualizing an idea of who you want to be in the future that is not yet realized, and then action planning in the direction towards that future-oriented self-conception can change behavior in the now. So for instance, if I'm not physically active, but I'm about to become a new grandmother and I want to be an active person in that grandchild's life, then that future-oriented self-conception of being a grandmother would motivate me to start my ankle ABCs now, and then I'm going to work up to leg strengthening, and then I'm going to work up to maybe walking around the block, and then I'm going to work up to walking around the block twice, etc., so that I can see that future-oriented self-conception become a reality. So the possible selves, I find, is actually quite helpful. Motivational interviewing, as a well-tested intervention, it helps orient people's intrinsic motivation to change, and it does outperform traditional advice giving. Remember, just telling people what to do is not enough. And you can Google readiness ruler and find 1,001 examples of this, but basically you give them a numeric scale and you say, on a scale of 1 to 5, how likely are you to do ankle ABCs today? And they might say, well, maybe a 3. And then you could ask them, well, what made you pick a 3 instead of a 2? And then they language whatever their answer is, and then say what need to happen to move you from a 3 to a 4. And that helps them organize their own internal dialogue towards accomplishing the new behavior. So the key takeaways is all of us that have interactions with older adults who are not yet physically active have an opportunity to help them achieve these benefits, because even at the cellular level, physical activity increases mitochondrial DNA. So we're at a cellular level changing their physiology. And so even something as simple, starting with ankle exercises and working your way up as tolerated and as conditions allow, really will help them go a long way. It might in the short term help them with something like constipation or pain control or depression or isolation or loneliness. But in the long term, it can really make a difference in their lives. And gerontologic nurses have an opportunity to play a big role in that. And these are my references. And that's me coming almost last in the half marathon in Vermont. And it doesn't matter because I got the same medal as the guy who won. And so it doesn't matter how fast you are, it's just that you bothered to do it. And here are my contact information. And I welcome comments and questions.
This was amazing, Dr. Hall. This is my first time learning about the talk test.
Oh, good.
And make sure I prescribe these based on the talk test. This is a really good example. Very nice. Any questions or thoughts or suggestions or anything that you...
One other thing that I wanted to share is that if you think about even something like knitting,
Oh, yes.
counts, because if you have arthritis of the hand and knitting helps you move the joints of your hand, and you need that hand range of motion to hold a spoon to feed yourself or to hold a brush to comb your hair, then knitting counts as physical activity. I think that we need to change our conceptualization of what counts. And you don't have to look good in spandex and be able to bench press any certain amount, that 100% of us can move.
Exactly, exactly. Yeah, even the small things count.
The small things add up to big things, yes.
Exactly, exactly. Any other ideas, or you can leave any chats if you're shy to ask any questions, Dr. Hall, to Dr. Hall?
Should I stop sharing or
You can stop sharing, yes.
okay.
Yes. Yeah. Anne, do you have any question?
Oh, well, first I wanted to apologize because I didn't realize my microphone was on when I was talking to one of my kids. So, I love your philosophy about just like, as even as I was here, I was like, wow, you can actually get a lot of movement in your foot doing those letters. And as we were speaking, I went on to the American Heart Association's webpage. Full disclosure, I have a family member who works doing marketing for them. And of course, it's like, oh, you should have proper shoes. And if your shoes don't feel good, you should get new shoes. Well, good running shoes are $100. Like, these are the things that people think they need to have to quote do activity, strong physical activity. So I so appreciate your philosophy because, and just that, first of all, because you make it doable, right? Like,
Right.
that idea, like, oh, okay, I am doing something, I think is such a confidence builder for people,
It
and
builds
then they
their
can,
efficacy.
yes, they can see
And if you
themselves
have
doing
no
it.
efficacy, the likelihood you're going to do something is pretty low.
Yeah.
So
And
we need them to become efficacious in this. So you give them things that are completely achievable. Sometimes I've actually had older women specifically tell me, when I don't feel like doing anything, I stretch, because that counts too. And I'm like, that's good. If just stretching is all you can muster for the day, then stretch.
yeah, so I like
It
that.
still
And
preserves range of motion.
Yes.
I appreciated your uh, theoretical foundation and that possible selves. That was a new one to me. So I'm going to look.
Well, and it's my favorite one to use. And the reason why is, even back in Charles Dickens' day, we see that Ebenezer Scrooge changed his behavior because the ghost of Christmas future showed him what a miserable life he was going to have. And showing this future oriented sense of self made him realize, oh my gosh, I'm not very nice. And so this is not a new idea, but we've really not used it enough to say, where do you want to be in 1 year, 5 years, or whatever, 1 month, 1 week? And how are you going to map yourself to get there? And actually, if you use the full possible selves theory, one thing you ask them to do is say, articulate your hoped for self, and then articulate your feared self, possible self. And now how can you map towards your hoped for self, creating discrepancy between your hoped for and feared self? So even if you don't fully achieve the hoped for self, you're still nowhere near your feared self. Yeah. And the nice thing about that is that you actually have an opportunity to work with anybody of any culture, because their self-conception is uniquely their construction. So I'm not telling anybody who they are supposed to be. They're saying who they want to be, and then they're coming up with the action plan to get there.
You know, this was short, Dr. Hall. We should have a longer conversation about this physical activity and aging, and this was very helpful. Thank you so much for your wonderful presentation. I learned so much. Talk test and future selves. That was a takeaway message. And in next month, we have Dr. Kim Oosterhuis, who will be presenting about the facilitating the See Me program in April 16th at this time here in Zoom. So stay tuned. And also, I provided the link for the quick survey for the feedback. So if you have any time, please fill out the survey for us to improve future selves. Thank you so much, Dr. Hall, and thank you so much.
Thank you, everybody, for coming.
Here. Yes, wonderful.
Thank you.